Hello, everyone. I think we're all ready to start our afternoon session. Our session here today is going to be on critical care pharmacy. I'm excited to present our speakers for this afternoon. I'm going to start with our first guest, Dr. Lama Nazar. She's a clinical pharmacy specialist at King Hussein Cancer Center in Amman, Jordan, with over 20 years of experience in critical care. She leads pharmacy research and education and is actively involved in international healthcare initiatives, both locally and internationally. Please welcome Dr. Lama.
Well, good afternoon, everyone, and thank you very much for the intro. The first thing that I probably want to start with is just to thank the organizing committee for such a great conference. It's the first time for me in Kuwait and the first time for me attending such a conference. And I have to say that I've been extremely impressive. So it's congratulations on a great conference and congratulations to such organization. So the topic that I'm going to talk about today is the use of beta blockers in shock. And there are three main points that I'd like to go through briefly during my talk. The first part is just to briefly discuss the rationale for using beta blockers in shock. And the focus is primarily on septic shock, since that's where most of the research has been done. And then we'll talk about some of the clinical evidence regarding the use of beta blockers in shock. And then based on that, what is the actual role of beta blockers in patients with septic shock? So I'll start a little bit about the pathophysiology, and again, without going too much into the details, but the part that I'd like to focus on is that related to the sympathetic nervous system. And I think we're all familiar with the fact that during septic shock, there is activation of the sympathetic nervous system, and that's something that's necessary. It's a necessary response as the host is trying to defend the pathogens that are invading. So there's stress hormones, there is pro-inflammatory cytokines that are released, and that's considered as a compensatory mechanism. Again, it's a necessary mechanism to defend during the process of septic shock. But what happens is if the activation of the sympathetic nervous system becomes prolonged or profound, and it's that excessive activation of the sympathetic nervous system that's considered as having a detrimental effect or considered as being pathogenic. And it has various implications or various impacts on various systems. The one that we most commonly think about is the cardiovascular system. So we see prolonged tachycardia, there's the decreased stroke volume and cardiomyopathy, but it's also considered to have an impact on other systems. So there's the immunologic system, also an impact on coagulation, and also impacting the endocrine system. And there's a lot of research that's been done looking at whether that prolonged activation of the sympathetic system would actually have negative impacts on patient and would impact the patient outcomes. And a lot of the focus has been primarily on the cardiac impact, because that's probably the one that we can mostly quantify and measure, especially if we're looking at tachycardia. And that's where a lot of the research has been done. So this is a study, which was a fairly large study, a multi-center observational study looking at over 700 patients. And they looked at tachycardia and mortality, so trying to see if there's an association between tachycardia that patients develop and mortality. And they looked at T1, which is the first hour of initiating norepinephrine in patients with septic shock. And they looked at 24 hours after the initiation of norepinephrine. And the part that they were looking at, again, was the association between tachycardia and mortality. So what you see here on this graph, the first one, which is on the left side, is for the T1, so that's the first hour of the vasopressor infusion. And then the second graph is for the second hour, the 24 hours, so that's 24 hours after the initiation of vasopressors. The blue bars are for patients that did not have tachycardia, and the red bars are for patients who had tachycardia. And if you look at both sides, whether it's T1 or T24, you can see that there was a higher mortality in patients that had tachycardia. For some it was statistically significant, for others it was not, and they stratified patients based on the dose of norepinephrine that they received. But the other interesting part in that study was that patients that had tachycardia at T1, so at the initiation of norepinephrine, at the start of septic shock, which we considered as kind of the compensatory phase, those patients who continued to have tachycardia at T24, so 24 hours after septic shock, had higher mortality compared to patients who did not have tachycardia at 24 hours. So that again takes us back into that compensatory mechanism and into the deleterious effect that initially it could be beneficial, but then continuing to have that stimulation or that activation of the sympathetic system could have negative outcomes on the patients. And from that, there were several studies that actually started looking at whether we can reduce tachycardia so that potentially we could improve patient outcomes based on that hypothesis. So this is one of the first studies that came out, which was by Morelli et al. It was a randomized controlled trial, open label, controlled, single-centered, and they took patients who had septic shock and were initiated on norepinephrine, and continued to have tachycardia 24 hours after the initiation of norepinephrine. And their definition for tachycardia was a heart rate of greater than 95. And those patients were randomized to two groups, either that they continued to treat them based on conventional therapy, so without having to control the tachycardia, or they randomized the patients to the other group, which was on esmolol. So they started the patients on a continuous infusion of a beta blocker to keep the heart rate between 80 to 94. And the endpoint, the primary endpoint for that study was heart rate between 80 to 94, so making sure that those patients' heart rate was maintained within that limit. So in other words, it was trying to see if controlling that heart rate would improve patient outcomes. And if you look at the figure, the left side is looking at the impact on heart rate, and it's pretty obvious. You know, you're starting a patient on a beta blocker, and you're targeting a reduced heart rate. So the group that was in the esmolol that received the esmolol infusion, which is the dark line, had a reduced heart rate. And if you look at the blood pressure, this is the part that we usually are concerned about. You start a beta blocker, does that mean that I need to increase the vasopressors and that patient may become hypotensive? The blood pressure did not change significantly between the two groups. And the interesting part is that they did not require increasing the norepinephrine dose for those patients that were on esmolol. In fact, they were able to actually start reducing the norepinephrine dose, suggesting that those patients hemodynamically were probably doing better as we're controlling that supposedly sympathetic nervous system. The part that was very attractive about the study was actually the impact on mortality. So if you look at the mortality between both groups, between the esmolol and the control, and let's look at the 28-day mortality, it was close to 50% in the esmolol group compared to 80%. And even if you look at the ICU mortality, it was also a significant difference between both groups, a 57% versus an 88% mortality rate between both groups, and that was statistically significant. Now, there was a big question mark in terms of that high mortality. You know, that 80% mortality rate seems very high for a patient with septic shock and much higher than what we generally see within the literature and what we see within our practice. But still, it gave that positive, at least it supported that hypothesis that controlling the heart rate could actually improve outcomes. And following that, there were several studies that came out. This is a meta-analysis that we published recently looking specifically at randomized controlled trials that evaluated beta blockers in patients with septic shock. And if you look at the studies, there were a total of 8 studies that were published at the time that we completed that meta-analysis. All of those studies were looking specifically at esmolol as the beta blocker. If you look at the sample size, it was a relatively small sample size, and the majority of those studies were single center, and they varied in terms of the endpoints that they had. But overall, the findings of that meta-analysis and the results of those studies were still positive in terms of suggesting that there is a positive impact from adding the beta blockers and controlling tachycardia. So this is looking at the effect effect on the heart rate, and it was positive in favor of beta blockers, that beta blockers would control the heart rate in patients with septic shock once you initiate them. And this was specifically looking at the effect on the 28-day mortality, and again, it was in favor of beta blockers. So the majority of the literature that we've had so far has really suggested that controlling tachycardia in patients with septic shock would have positive outcomes. Things started taking kind of a different direction. Things are never black and white with ICU, so it just gets even more complex. But these are two studies that really turn things around in terms of controlling tachycardia, beta blockers, in patients with septic shock. The first one is the STRESS-L study, and the second one is the LANDI-SEP study. Both, again, were looking at what previous studies have looked at in terms of controlling tachycardia in patients with septic shock. The first study, which was the STRESS-L study, was a randomized, open-label, multi-center study in the UK. And in that study, they also, kind of similar to previous studies, took patients who had septic shock and had tachycardia, which was defined as a heart rate of greater than 95 beats per minute. And if they continued to have that tachycardia at 24 hours, they were randomized either to a beta blocker group or to the conventional therapy. Now, the difference between these two studies and the previous studies is that we're looking at a different beta blocker that was used here. So the previous studies, if you remember, were all looking at esmolol. And here, this study and the next study that I'm going to talk about, we're looking specifically at landolol. So it's a beta blocker. It's given as an infusion. It's short-acting, but it's not esmolol. And I'll talk briefly about some of the differences between them in terms of the beta-2 selectivity. The primary endpoint was the mean change in the SOFA score from the time of initiating treatment until 14 days. The study was terminated early, which was kind of surprisingly in terms of the end result for that study. It was terminated prematurely by the trial sponsors due to concern that it doesn't seem to be adding benefit, and there was some concern about harm. So there was a signal of possible harm from giving landolol in those patients. They had enrolled 63 patients in both arms, so there were 63 in the landolol group and 63 in the conventional group. There was no difference in the primary outcome, which was the change in the SOFA score, but the part that was concerning, and that's where there was a signal of harm, was with regards to the mortality. It was a secondary outcome, but again, it was a signal of harm. The 28-day mortality was 25% for the standard group and 37% in the landolol group. And again, the study was terminated prematurely due to that concern. The second study was the LANDI-SEP study, and that was also a multi-center study, but they included other European countries. So the previous one was just the UK centers. Here we're looking at also European countries that were included. But it was kind of similar in terms of including patients who had septic shock, they had tachycardia, and they were randomized to either the landolol group or a placebo, trying to control the heart rate in those patients. And the primary endpoint for that study was the combined heart rate response and the maintenance, being able to maintain the vasopressor requirements. If you look at the primary response in terms of the heart rate control, there was a statistically significant difference between the landolol group and between the control group, which was pretty obvious. Again, being able to control the heart rate with a beta blocker, you will definitely be able to achieve that. The secondary endpoints in terms of the mortality was not different between both groups, so that was not statistically significant. But the authors of that study suggested that within the context of the previous study and the findings from this study, that this does not support a treatment strategy of stringent heart rate control in patients with septic shock. Now the question is, why the discrepancies? We've gone from moving in the direction of saying that tachycardia is bad and we need to control tachycardia, and if you do that it actually improves the patient outcomes, into a different direction where we're saying that controlling tachycardia, there's a signal of harm and that we should not be doing it for our patients with septic shock. Now there are multiple hypotheses in terms of why we're seeing those differences. If you remember the first table that I showed, most of the studies were single-centered and most of them were relatively small sample sizes. So that could be one of the reasons in terms of not being able to see that impact when you're looking at more diverse patient populations. Studies were conducted several years ago. So the first study, the Morales study, was conducted more than 10 years ago. And now we're looking at more recent studies. And throughout those years, the practice has changed, our ICU care has changed, and the recommendations have changed. So is it just the beta blockers that are making that change? Is it just the tachycardia? Or is it change in the way we manage our patients that's actually resulting in those discrepancies that we're seeing? There's also heterogeneity among our patients with septic shock, and I think the more we hear people talk about this, the more we realize that septic shock is just not one disease. There is a lot of heterogeneity in terms of what the underlying causes are, whether it's for the disease itself or for the patients also. And then what I mentioned earlier, that the initial studies were looking at esmolol, and the last two studies were looking at landolol. They're both beta blockers, but they vary in terms of their beta 1 and beta 2 ratio. Landolol is considered as more beta selective, beta 1 selective. So does that suggest that you may see different outcomes, or is it just that beta blockers should not be considered to begin with? So it's a huge difference in terms of the selectivity, the beta 1, beta 2 selectivity between landolol and between esmolol. It's a difference of 255 versus 33. Prior exposure to beta blockers, and there's more data coming out saying that patients that have been exposed to beta blockers previously or were on chronic beta blockers previously may respond differently to beta blockers when they're initiated for tachycardia. And that was not addressed in some of the previous studies. So could that be a factor for why we're seeing a response or why we're seeing benefit in some of the studies? We're not seeing it in some of the other studies, especially that we're looking at relatively small sample sizes. And then we also need to keep in mind that there are various causes of tachycardia. So there's a lot of those studies were making the assumption that tachycardia is due to the excessive stimulation of the sympathetic nervous system, but we clearly understand that there's a lot of other reasons. Pain is the first thing that usually comes to our mind, and there's a lot of other reasons that could cause tachycardia in someone who's in the ICU, regardless whether he has septic shock or not. And then it's also, I think that's the very important part, is being able to distinguish between the compensatory mechanism and between the disproportionate tachycardia that we get. And I don't think patients follow a strict timeline. So we can't say that at time 24, then that patient switches from a compensatory phase into a deleterious phase of the activation. So where do we draw the line? That's very difficult to determine. And I'm sure it varies depending on the patient and depending on the setting. So just to kind of summarize, what we've gone through, septic shock clearly is associated with increased stimulation of the sympathetic nervous system. And the initial studies clearly demonstrated that there is improved outcomes in patients with septic shock and tachycardia and those who receive esmolol to control that tachycardia. The recent evidence that evaluated landolol did not report benefit, and there was a signal of harm. So based on that, we cannot say that we should be universally or routinely treating tachycardia in our patients with septic shock. There's a lot of future research that's needed to really understand the role of beta blockers. Most of the studies did not have any form of electrocardiography or echocardiography monitoring that's going on, so it's hard to tell exactly what the underlying cause of tachycardia was, and to really determine the impact of beta blockers on the cardiac function. So that's one thing that was certainly missing from a lot of the studies. There's so much that we need to determine in terms of which patient population may benefit. Maybe beta blockers truly have a benefit in that setting, but there's probably a subset of patients that would benefit, and that needs to be clearly defined. What's the most appropriate beta blocker to use? Is it esmolol that really gives us the benefit, or is it landolol that's doing the harm, or is it something else that we're missing there? When do we initiate, and for how long do we treat, and what are the goals of treatment? And I think throughout the years, we've realized that normalizing values in our critically ill patients is not always the solution, whether it's tachycardia, whether it's hyperglycemia, whether it's a lot of other factors that we've tried to normalize, thinking that that would actually improve the patient outcomes. We've realized that that's not the only thing that we need to be doing. So we need to understand whether it's tachycardia that we need to treat, or maybe there's something else that we need to monitor to determine how we can optimize the treatment for our patients. So with that, I get to the end of my talk. Thank you very much for listening, and thank you very much for having me.
Thank you so much for such an informative talk. We're going to leave the questions till the end of the session, so please hold on to your questions, and we're going to leave it for my next.
Yeah. Good afternoon again. Honestly, I'm happy to be among our greatest clinical pharmacists here around all over the world. So let me welcome the next speaker. She's Dr. Nada Al-Khani. She's a distinguished consultant clinical pharmacist in critical care with marked contributions at King Fahad Medical City in Riyadh, Saudi Arabia, and also an adjunct clinical assistant professor at Al Faisal University College of Pharmacy and King Saud University. Welcome, Dr. Nada. She's going to talk to us about the power of antimicrobial therapeutic drug monitoring in ICU patients. Welcome, and go ahead, Dr. Nada.
For this very prestigious and wonderful critical care conference here at Kuwait. It would be my pleasure today to talk about the power of antimicrobial therapeutic drug monitoring in ICU patients. So today we will entertain going over the PK/PD in ICU patients, looking into the essential role of therapeutic drug monitoring in those patients while optimizing antimicrobial dosing, and also demonstrate the available evidence that would support therapeutic drug monitoring. So in patients with septic shock, prompt administration of appropriate antibiotic is very essential, and providing the precise dose is very important. And when I'm saying precise and appropriate dosing, I am talking about the amount of drug that reaching the infection site to get the optimal outcome, the clinical and also microbiological response we're looking for. Our ICU patients are very special, and also they are special in terms of pharmacokinetic, pharmacodynamic, as part of other patient special population. So whenever I'm giving a drug, a dose of a drug, I am expecting a specific concentration of the patient's blood, and that would be the pharmacokinetic, which is the impact of the body on administered drug, where this concentration reach the specific target site to exert its effect and also give the clinical outcome we are looking forward to, which is the pharmacodynamic, that is the impact of the drug on administered body. So what would be the challenges of antimicrobial therapy in ICU patient? There is actually multiple challenges, starting with the pathophysiological changes that would affect or alter the drug absorption, distribution, metabolism, and elimination in those patients. The renal and liver impairment that could happen, also the fluid shift with vascular permeability changes in the fluid volume that we are administering to our patient, in addition to the significant hypoalbuminemia that could be increased in those patients and affect drug protein binding. So in septic shock, we are expecting multi-drug organ, and those different organs that could be altered or affected also is affecting our pharmacokinetic of the patient body as well, looking into liver and cytochrome P450 changes, also renal failure, and you name it. So let's go over the pharmacokinetic consideration that could happen. So starting with the absorption, delayed gastric emptying and impaired interstitial absorption. All those vasopressors that we are giving our patients is really shunting the blood to the vital organ, leading to the non-vital organs to have a diminished blood flow that would affect the absorption. Also, all this feeding tube. So we're expecting adherence of the drugs to those plastic lumen as well. So oral absorption would not be our best option for those patients. Going into distribution, the changes in protein binding and the fluid shifts, particularly in highly protein drugs, the capillary leak and the fluid resuscitation is changing the volume of distribution in those patients and affecting mainly hydrophilic drugs. Metabolism is very much affected by liver failure and the changes in cytochrome P450 enzyme activity that can be reduced. And lastly, the excretion is affected by the renal impairment and also the use of renal replacement therapy that complicates drug dosing or having augmented renal clearance. So the three major factors that I would look at whenever I'm dosing antimicrobial in my ICU patients, number one is the volume of distribution that will be changed and increased. Also the drug clearance, either increased or decreased. And lastly, the tissue perfusion, because I am expecting impaired microcirculation result in poor drug distribution to the infection site. Also, the use of different extracorporeal therapies and drug, looking into the administration of ECMO or renal replacement therapy. Whenever we have an ECMO on a patient, we are expecting drug sequestering and also the changes of volume of distribution. And that's a very big topic that I'm not looking at it during my presentation. At the same time, CRRT is affecting my antimicrobial dosing and very much depend on effluent rate and membrane characteristic as well. So the element or the pillar with therapeutic drug monitoring in ICU patients, starting with the patient characteristics, as we talked about PK/PD changes, the drug property, therapeutic drug monitoring implementation program, and also the expert interpretation. So now we can go and look into the different drug properties that we are experiencing or dealing with in ICU. So we have hydrophilic drugs and lipophilic antimicrobials. So in terms of hydrophilic antimicrobials in ICU patients, we are anticipating increase in volume of distribution, changes in clearance depending on renal function, either impaired or augmented, and also decreased interstitial or intracellular perfusion. And that's very much, we see it with beta-lactams, aminoglycoside, vancomycin, colistin, and those are very much the challenging dosing when it comes into ICU dosing. Lipophilic antibiotics does not really affect it much in terms of pharmacokinetics, so volume of distribution will not very much change. It depends on hepatic metabolism mainly, either increase or decrease. However, they does not have any change in terms of intercellular penetration, and that's very much with fluoroquinolone, macrolide, clindamycin, linezolid, and azoles antibiotic as well. With beta-lactam antibiotics, they are time-dependent, very much depends on the fraction of time above MIC. Our target is to have 100% of the time above MIC. They have a wide therapeutic range and therapeutic index, which is, luckily, that's a great thing. We don't have a specific drug concentration monitoring for them. However, high exposure can lead to neurotoxicity, especially when it comes into cefepime and piperacillin tazobactam. So dosing modality of beta-lactam very much depends on the continuity of, or the time above MIC. And there is multiple trials that looked into the continuous versus intermittent administration of beta-lactam. And the two recent published multinational randomized clinical trials, the MERCY and the BLING-3 trial, have added substantially to the body of the evidence in general. So in MERCY randomized clinical trial, they examined the continuous infusion of 3 gram meropenem over 20 24 hours versus intermittent administration of 1 gram every 8 hours over 30 minutes. And actually, they did not find any significant difference in terms of all-cause mortality or pan-resistant bacteria at the day of 28. Also, in a Blink-3 randomized clinical trial, they looked into beta-lactam continuous versus intermittent infusion. They examined patients receiving piperacillin tazobactam or meropenem over 24 hours versus intermittent over 30 minutes. And also, they did not find a significant difference in terms of all-cause mortality at day 90. Recently, in 2024, Dr. Abdulaziz published his meta-analysis of 18 randomized clinical trials, and he included MERCY and the Blink-3 trial to his review as well, including around 9,000 critically ill adult patients with sepsis and septic shock, and looking into all-cause mortality at 90 days. And interestingly, the analysis found that there is a risk reduction with prolonged infusion with 0.86 estimated risk ratio with 99.9 posterior probability, as well as a decreased risk ratio in ICU mortality with prolonged infusion and increased risk ratio of critical cure with prolonged infusion as well. So that was very interesting. That would keep the debate of continuous versus intermittent infusion in beta-lactam. And when you looked into the results in terms of primary outcome or the subgroups, you can see that it's very much favor the prolonged infusion over the intermittent infusion, as well as with secondary outcome looking into clinical cure, microbiological cure, as well as ICU length of stay. So now the question is, how about the new beta-lactam, beta-lactamase inhibitor? There is actually no pharmacokinetic, pharmacodynamic studies that looked into those new agents. So the best way to dose those agents is to look into the pharmacokinetic property of the drug as well as the clinical scenario of your patient. As you can see here, most of those antimicrobials get affected by renal function and needs to be dosed based on renal function. They are not very much protein binding property, and their pharmacokinetic, pharmacodynamic targets very much affect on having them as the longer time as possible above MIC. For vancomycin, our lovely hydrophilic drug that we always do therapeutic drug monitoring in ICU, it has increased volume of distribution and clearance. It is time dependent, and there is some studies that demonstrate that Cmax over MIC ratio to be equally important in vancomycin. Having area under the curve above MIC by 400 to 600 is recommended for Staph aureus, and the higher exposure are probably needed specifically in critically ill patients. There is multiple studies that look into prolonged versus high exposure of vancomycin, but actually it was found to have nephrotoxicity. So a systematic review and meta-analysis concluded that vancomycin therapeutic drug monitoring significantly increased the rate of efficacy and decreased the rate of nephrotoxicity, and that's what we actually know for years. Cardell and his colleague, examining the therapeutic drug monitoring of vancomycin using trough levels, he found that it resulted in faster target concentration attainment and more rapid discharge from hospital, clinical stability, and shorter course of vancomycin. Neely and his colleague also looked into the AUC versus trough-based therapeutic drug monitoring, and he found that AUC is superior with regard to reduction in nephrotoxicity and shorter therapy time. When it comes into clinical practice, it depends very much into the institution and the availability of AUC systems they have. In my practice, I still use trough level monitoring in terms of vancomycin, as I feel it's easier with ICU patients with altered renal function. Colistin, also it has very unique pharmacokinetic. It's concentration dependent with narrow therapeutic index. It has a protein binding between 60 to 70%, and the elimination very much depend on renal elimination in colistin. It has very unique pharmacokinetics, starting with its being an active prodrug that undergoes complex transformation before reaching its active form. It has very significant inter- and intra-individual variability in terms of pharmacokinetic that may lead to inconsistent plasma concentration. And in patients with renal function, the worse the renal function is, the higher the percent of the prodrug that would be converted into active drug, which may lead to increased toxicity as well. So as you can see in terms of dosing with colistin, loading dose is always very high. Loading dose actually is very important when dosing colistin. And then for maintenance dose, we go by renal function. AUC over MIC seems to be the best PK/PD index for colistin. Sorley and his colleague look into trough level of 2.4 milligram per liter that would be associated with nephrotoxicity, suggesting that a trough level of 2 milligram per liter can be optimal in terms of efficacy and toxicity. However, in real practice, we don't have enough it's very challenging, actually, to do colistin therapeutic drug monitoring, although it can be very interesting, and it would be very great for our patient to have therapeutic drug monitoring of colistin. So lastly, I found it very interesting to look into this trial that evaluates therapeutic drug monitoring for antibiotic optimization in critical care, and to see how can be effective in using different therapeutic drug monitoring in those patients. And this comprehensive systematic review and meta-analysis by Takahashi and his colleague that included 5 randomized clinical trials with around 1,000 patients. To evaluate the effectiveness of therapeutic drug monitoring-based regimen, they found around like 26.9% of mortality, but it was not very much significantly different from using standard dosing of control group. There was no significant difference in terms of secondary outcomes in hospital mortality, clinical cure, target attainment, or ICU length of stay. If you can look into those 5 different trials, the antibiotics that used in this review as aminoglycoside, piperacillin, tazobactam, meropenem, beta-lactam, Cipro, in general, vancomycin as well. So in conclusion to this review, they did not find a significant benefit, and they suggested further research to be done. So generally speaking, when I talk about drug dosing optimization in ICU patients, administering enough drug at the beginning is very crucial, and looking into the drug property. So in hydrophilic drug, increasing loading dose for concentration-dependent drug is very important. Then we can consider continuous or prolonged infusion with beta-lactam and adjust dosing based on creatinine clearance. In lipophilic drug, which is easier to dose in ICU patient, weight-based dosing is important in obese patient, and then adjusting based on hepatic impairment if needed. Talking about innovation, technology advancement is needed for therapeutic drug monitoring in terms of having more point-of-care testing, pharmacokinetic modeling, and also the integration of artificial intelligence will do a lot, or will make a big change in therapeutic drug monitoring. Pharmacists would have a great role in pharmacist-led therapeutic monitoring services because they are very much expert in pharmacokinetic. They can collaborate with interdisciplinary collaboration team and have educational initiative. Thank you so much for your listening. Those are my references, and thanks a lot.
Thank you very much, Dr. Nada, for the great, concise presentation. Again, we'll move to the question at the end of the sessions. We'll move to the next speaker, with Afrah.
Yes. Our third distinguished speaker is Dr. Uhud Al-Jahni. She's an associate professor of pharmacy practice at King Abdulaziz University and a pharmacy residency program director at King Abdulaziz University Hospital. She is also a pioneer in critical care pharmacy research in Saudi Arabia and the founder of the Saudi Critical Care Pharmacy Research Platform. Please join me in welcoming Dr. Uhud.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. I extend my appreciation and thanks to the organizing committee as well as to the scientific committee in putting together this outstanding conference, as well as a well-thoughtful topics and a program that is speaking to a multidisciplinary audience. Today I'm going to talk about, or trying to answer a question, is the road to using ketamine-based sedation clear yet? Or maybe leaving you with more questions by the end of this presentation. To begin with, I don't have any, it's not, the slides is not moving. Oh, right there. I have no conflict of interest in relation to the content of this presentation. As an academician, I always like to have learning outcomes out of my talks. So hopefully by the end of this lecture, you will walk away with understanding some key feature. I'm sure you are in the room, have dealt with ketamine. It's not a new medication. It's been in practice since 1970. So I just gonna refresh you with some key features of ketamine. What make it a unique sedative in comparison to traditional sedative agent that we are using? Recognizing some potential application in ICU sedation for ketamine. When I'm talking about sedation, I cannot exclude opioid consumption. I cannot exclude as well as the delirium incidence or rate of delirium when we are dealing with sedatives. Throughout my presentation, I will talk about some research finding on the utilization of ketamine in ICU setting, trying to shed lights on some of the key aspects in relation to sedation, analgesia, and delirium as well. Just for a quick start, what we know about ketamine. Traditionally, it is a non-competitive NAMDA receptor antagonist, is known as anesthetic, has been used for years. It provides profound sedation as well as analgesic effect. Why we are here talking about ketamine? There is an emerging interest over the last few years, probably since the publication of the latest BADIS guideline in 2018, us as a practitioner may be confused or reluctant or hesitant to use it as a sole sedative agent or as a primary sedative. But there is a lot of growing interest, as well tons of publication that I might not capture in my presentation today, talking about its impact on managing pain, agitation, and delirium in a critically ill patient. Current status, we know its potential benefit, but we know also its potential limitation. And that's why we try to clear up some aspect today in this presentation. What the latest version of the BADIS guideline suggests? Well, in terms of ketamine, there was one statement about its use in post-surgical pain, low dose of ketamine in post-surgical pain. There was no any recommendation about routine use of ketamine for specific sedation management or delirium in ICU patient. However, the guideline emphasized in using non-benzodiazepine sedative, like propofol, dexmedetomidine. Why ketamine might be different, we'll see over our presentation. So still the first line agent for sedation and delirium management, or we know that for symptoms of delirium management, we can utilize non-benzodiazepine. Also, the guideline emphasizes on analgesia first sedation or analgesia-based sedation. And keep in your mind that ketamine can hit also opioid receptor. It can work on delta as well as a mu receptor in certain dosing regimen or dosing range. So it might also provide some analgesia in that aspect. What makes unique aspect of ketamine? Why ketamine is different than other sedative agents? I'm going to focus on 3 aspects, and probably I will not bother you with tons of pharmacological information or pharmacokinetic information, but the 3 key important characteristics that I will highlight is the preservation of respiratory function, the preservation of hemodynamic stability, as well as its impact on gastrointestinal motility. So ketamine can preserve cardiovascular stability. This is of interest in our hemodynamically unstable patient. So even if you have patient with hypovolemia, trauma, or asthmatic patient, this is make it useful for them. It can increase the blood pressure slightly or heart rate, which is unlike other sedative, and can maintain the blood pressure and heart rate. However, we have to keep our mind also from this, which could be a disadvantage in hypertensive patient or patient with acute coronary syndrome. It provides bronchodilatory effect. So if you have asthmatic patient or COPD patient and coming to your ICU, this is maybe an agent that you can feel comfortable to utilize. It also could be utilized in people with asthma and COPD exacerbation. As I mentioned, it preserves respiratory drive. Maybe of less concern for mechanically ventilated patient, but if you have a spontaneously breathing ICU patient, this is of really interest in reducing the risk of respiratory depression. What about its impact on gastrointestinal motility? Specifically in post-surgical patients? Well, they found that maybe initially ketamine can slow gastrointestinal function. However, the study I mentioned here is found that low-dose infusion can help patients regain their bowel function after surgery more quickly than those who didn't receive ketamine. So to a certain extent, it might improve gastrointestinal motility. Again, a specific patient population. I cannot say it's for every ICU patient it will happen. Okay, all these advantages coming with disadvantage. So there are some side effects. Some of them are common, some of them are minor, some of them are very rare but life-threatening if happen. And some are related to the doses that you use. Higher doses and rapid administration may cause some of these side effects. The common one that make us as a practitioner reluctant or hesitant to reach out to ketamine will say increased saliva production, specifically in ICU patient, intubated, sedated. This might increase the risk of aspiration, as well as the risk of vomiting might increase risk of aspiration, which require continuous monitoring and preventive measure in order to avoid these side effects. Emergency reaction, I hear it a lot from my physicians at bedside that it could develop in some patient. It may cause also delirium, and that's require close monitoring as well. Laryngospasm, the spasm of the vocal cord, is a serious also concern, especially when you are dealing with airway management. Another important aspect is the pharmacokinetic of ketamine. It's very appealing. The onset of action, and this is coming from a study basically in the pre-hospital setting or emergency department where we need rapid control of acute agitation. It found that average onset time for effective sedation to control acute agitation around 7 minutes. In comparison to traditional agents such as benzodiazepine and antipsychotic, this range from 15 to 30 minutes. And just think about it if you are in a pre-hospital setting and try to control a very agitated patient, you would reach out to something that is quickly have a quick onset of action, such as ketamine. Ketamine dosing strategy. With different dosing, you get different mechanism of action and hitting different receptor. We can utilize it also in different routes, IV as well as intramuscular. To some extent, I found some report of subcutaneous administration as well. We can use initial doses, typically 1 to 2 milligram per kg IV as a bolus. If you decided to start it on for sedation, you can use continuous infusion as well. Adjunctive in a low doses, you can use it when you are using it alongside with other sedative as well. With all these advantages, side effect, as well as dosing strategy and pharmacokinetic, it is a very versatile agent. So we have a lot of uses in critical care. I did not enumerate all of them. Still, there is use of ketamine in status asthmaticus, status epilepticus. I have seen it in a status migraneous case at one time in our ICU. So there is tons of uses of ketamine around us in a critical care setting. It helps in airway management, specifically in difficult airway scenarios for induction of intubation with having preservation of respiratory drive. It could be used for short-term sedation and invasive procedure, even for pediatric patients. As I mentioned, rapid control for agitation and acute agitation in critically ill patient, even pre-hospital setting. And again, it could be utilized as a potent analgesic in pain management, either for acute, I have used it in a lot of trauma, as well as burn patient for acute pain and chronic condition. So why we are confused, as always in a critical care medicine research related? Because there is tons of evidence, and the evidence is inconclusive, either due to low quality of evidence or low uncertainty, or while there is combining evidence about ketamine benefit, there is a combining evidence about also some drawbacks, where left us very confused or reluctant to utilize it as a sole sedative agent. Well, there is a combining evidence from several studies published after 2018 until today, and I cannot capture all of them now. However, the theme of most of the study are that there is a reduction in opioid use, which is something that advantage that we always working hard in our ICU to minimize the opioid use, improving analgesia in mechanically ventilated patient, as well as effect on delirium, may be unclear, but some studies shows that it might reduce the incidence of delirium. Impact on long-term outcome after ICU discharge is still inconclusive, and still we have mixed evidence about that. So over the next few slides, I will just shed lights on some of those uses and try to summarize what I found in literature in terms of each one of these uses. As I mentioned, it could be used as dissociative sedative. This has been summarized in a systematic review, specifically in a pre-hospital setting, in a dose range from 3 to 5 milligram per kg, average onset time 7 minutes, and this is superior to traditional sedative agent. The study, the meta-analysis included 18 studies for more than 600 patients. They found that overall intubation rate was 30%, with a higher intubation rate in people who got ketamine pre-hospital and transported to the hospital by ground transport in comparison to the air or ED intubation. In terms of the safety, side effect, yes, there is side effect. The highest were the hypertension, up to 12%, followed by emergence reaction. What we concluded from this meta-analysis that ketamine provides a quick sedation when needed for agitated patient. We might keep an eye on higher intubation rate, specifically in the ground transportation. Side effects are there, however, are very common, but typically resolve without long-term complication. How about using it as adjunctive therapy in ICU sedation? There is tons of studies about that use. Well, traditionally, we reach out to something like propofol or dexmedetomidine, mainly non-benzodiazepine as first line. As a complementary agent, ketamine has promises and show a lot of beneficial reduction of opioid, as well as decreasing the sedation needs. So whom I should prescribe ketamine? If you see your patient not reaching the target RASS score and requiring high doses of either analgesia-based sedation or your traditional sedative, you might reach out to ketamine and add it as a complementary or adjunctive sedative. Specifically in those patients also who have contraindication. I have tons of cases where we have difficulty in sedating them. Happened a lot with COVID-19 patients that we needed. Specifically people with trending up triglyceride and still needing high dose of propofol for longer duration. An RCT was visibility, actually, open label RCT conducted in Saudi Arabia by Amir et al. Included 83 patients, and they are actually looking for ketamine infusion plus a standard of care versus a standard of care. Standard of care meaning any sedative or a traditional sedative agent. They looked to several outcomes and found there is no significant difference in terms of mechanical ventilation duration, ICU length of stay, and there is no difference also or serious side effect. Interestingly, ketamine has a higher percentage of the patient achieving goal RAS score either at a 24-hour or 48-hour. Well, it's a visibility study, so it just shows us that is okay to conduct such a study. It improves RAS goal without increasing sedation duration, no impact on mechanical ventilation, and no serious adverse effect, which is supporting its safety in a critically ill patient. Another study was a retrospective study conducted to compare ketamine versus non-ketamine-based sedation, and I think this was in an academic medical center. And they also looked to several outcomes with no difference in most of the outcome in days alive, even in days alive without delirium, slightly higher, and ketamine-based sedation didn't reach to a statistically significant difference. And there was no difference on incidence of delirium, incidence of coma, ventilator-free day. However, incidence of coma was higher in ketamine-based sedation, and this was alarming. So this study concluded that if we utilize ketamine-based sedation, we have to keep our eye on patients at higher risk of coma and monitor them closely when utilizing ketamine in ICU sedation-based. So the key here is to know your patient and which patient might benefit the most of ketamine. What about ketamine utilization or base sedation in COVID-19 patient? My group and I conducted this multi-center retrospective prospective cohort study to assess the safety as well as the effectiveness of ketamine-based sedation in a critically ill, mechanically ventilated COVID-19. Well, we looked to several outcomes. We found that hospital length of stay had significantly shorter and ketamine grew. Interestingly, also, there is an improvement in the BF ratio. And one of very surprising outcome, and this may link to its anti-inflammatory immunomodulatory effect that we need further investigation, that has faster normalization of lactic acid in COVID-19 patient. But we don't have any significant difference, neither in mortality nor in the duration of mechanical ventilation. So that suggests that we need more study in this regard, specifically talking about anti-inflammatory and also improvement in the respiratory function. Speaking about in that study was the BF ratio. So ketamine has a role in opioid reduction. As I mentioned, I can't talk about the sedative without shedding light on opioid reduction. Yes, in a target patient, if you know your patient, that's gonna be requiring high opioid, either patient with substance use disorder or people who have opioid tolerance, then introducing low dose of ketamine as an adjuvant along your primary sedative, it will be beneficial. Studies showed, this systematic review showed that ketamine has up to 30% potential reduction of requirement of opioid if utilized as adjunct. Also, in order to see opioid-sparing effect, we need to have 24-hour time frame or more in order to really anticipate ketamine opioid-sparing effect. Typical low dose of ketamine of 0.2 to 1 milligram per kg per hour is the typical for low dose for pain management.
2 minutes.
Ketamine and ICU delirium prevention, while often associated with increased traditional sedative, whether benzodiazepine or non-benzodiazepine to a certain extent, we might increase the risk of delirium. Ketamine has a potential to reduce that. Still, some studies shows not that, but however, it has a neuroprotective effect and can reduce opioid consumption, which ultimately might reduce the delirium. Still, we need further study in this aspect. So this meta-analysis conducted to compare ketamine with other ICU agents, and they looked to different aspects. I will focus on there is no difference on mortality, pain, opioid consumption, midazolam consumption, ICU length of stay. However, ketamine favored in delirium rate, but results are not reposed as the studies included in this meta-analysis is of low quality of evidence. So to wrap up my presentation, is ketamine ready for routine ICU sedation? I want to show by hand if you are convinced to use it. Okay, I see ones. Well, the answer is, well, it is well tolerated, have a safe side effect profile, and it has some potential. However, in order to conclude its use, we still need further data of high quality to can utilize it routine or as a solo sedative agent. It can provide some unique benefit, but knowing your patient and individualize your approach is very important, and know which patient-specific population. And I encourage all of us as a practitioner, academician, research, to conduct a lot of studies and high-quality studies on those patients in order to have a conclusive, or waiting for the pain, agitation, delirium guideline version, updated version to have an answer. Thank you all, and that's all for my presentation.
Thank you so much, Dr. Ahoud. Again, please save your questions for the end of the session, so we have the Q&A.
Okay, moving to our last, not least, speaker of the session, Dr. Patrick Shapsky. He's a clinical pharmacist in the cardiothoracic surgery ICU and ECMO program at Mayo Clinic in Minnesota, USA. He has a dual academic appointment as assistant professor in the fields of anesthesiology and pharmacy at the Mayo Clinic College of Medicine. He has well-known contributions in critical care research and education. So welcome, Dr. Patrick, and he's going to talk to us about ECMO, CRT, and anticoagulation, bivalirudin. Very welcome back, our welcome home. Go ahead.
Great. Thank you so much for the kind introduction, and thank you, first of all, to the organizers and the moderators for having me, and all of you for attending today. My disclosures are here. None of them are pertinent to the presentation today. When we discuss anticoagulation in ECMO, it's important to take a step back and remind ourselves what ECMO actually is, and more importantly, what it's not. So this is the formal definition from the Extracorporeal Life Support Organization. They say that ECMO is defined as the use of modified cardiopulmonary bypass to provide temporary life support in patients with potentially reversible disease. ECMO provides a mechanism for gas exchange as well as cardiac support to allow for recovery. And this is very important because what you don't see here is that ECMO actually treats any type of disease. And so while ECMO does not treat disease, it introduces many competing factors that disturb the normal coagulation balance. Some of these are included here, a very large surface area of non-biological substances, non-endothelialized surfaces that activate cytokines, the extrinsic coagulation pathway, and various inflammatory mediators. There's pumps that shear red blood cells and uncoil von Willebrand multimers. These are very large bore access that promote disturbance and hemostasis. These patients are critically ill. They have sepsis, infections, and other comorbidities that contribute to their coagulopathy. These patients have platelet and factor consumptions, excess fibrinolysis, and also a dilutional coagulopathy that's particularly relevant when they first go on ECMO and they're being resuscitated still. Also, depending on the severity of the illness, could have intraventricular blood stasis. And for all of these reasons, we often administer antithrombotics, which just further compound the coagulation disturbance. These are data from the ELSO registry of 80,000 ECMO runs, highlighting the adverse effects that are commonly seen during ECMO. And you can see in the red box that the adverse effects related to coagulation disturbance, whether it's bleeding or thrombosis, these are amongst the most common that are occurring during ECMO support. Now, on the more dramatic side, these are data from Germany, from a sample of about 300 patients that are receiving ECMO post-cardiotomy or for eCPR. 11 patients developed thrombus in the left ventricle, and you can see here that this was always associated with non-survivable outcome. Now, ECMO introduces many unique hemostatic considerations for support and the delivery of anticoagulation. The membrane lung is where gas exchange occurs, and this is the reason why we go on ECMO. And this is a device that has very tightly packed fibers where gas exchange occurs, but at the same time, this is a prime host for deposition of fibrin and growth of thrombus. Additionally, throughout the circuit, there's many areas where there's connectors and access points where fibrin likes to attach and grow. The membranes are amongst the most common place where fibrin and thrombus develops. This is actually very common during ECMO, and this is expected. But you can see here, after these oxygenators were washed with crystalloid after being used for support, you can see all of the fibrin and thrombus material that is left behind. And when you place these oxygenators under an electron microscope, you can see the extensive deposition of cellular and thrombotic material on these devices. And so what this does is it provides a very tight balance that we have to play when managing ECMO. On one hand, we have a scarce resource in the membrane lung, and that we need to deliver satisfactory gas exchange. And when that device thromboses, it reduces the efficiency of that, and we may not meet our clinical targets. But on the other hand, we also don't want to promote a situation where we have a non-survivable hemorrhagic event like you see here. Now, thrombin is a very critical player in the coagulation cascade, particularly as it pertains to thrombosis during ECMO. Thrombin is a serine protease that is activated when tissue factor is exposed to blood and damaged endothelium. Thrombin, of course, activates factors 5, 8, and 11, and it is really critical in the formation of fibrin and the ultimate stabilization of clot. Thrombin only takes a couple minutes to initiate, and once initiated, within 10 to 15 minutes, the thrombin levels increase nearly 10,000-fold. And this is very, very important when we talk about ECMO support because it shows how quickly thrombin acts in maintaining hemostasis. And this is really the reason why if you cut yourself shaving, for example, very minor cut, that you don't die from hemorrhagic shock, it's because of thrombin's quick actions. Now, during ECMO support, when you spike samples with tissue factor, you see that the development of thrombin concentrations are delayed as compared to non-ECMO controls. However, their peak concentrations are much higher than non-ECMO controls. And when you add thrombomodulin to these, there's a decrease in the activation of protein C, or resistance, in patients on ECMO. And this really underscores the procoagulant-anticoagulant factor balance that is heavily skewed towards hypercoagulability in patients receiving ECMO. And this is really the reason why we need to deliver anticoagulation to provide safe ECMO support. So bivalirudin is a synthetic direct thrombin inhibitor. It does not require a cofactor, unlike heparin. It has a very rapid onset and a short half-life. Its metabolism is organ independent. It's primarily metabolized in the plasma by esterases, and there's a portion of it that's excreted in the kidneys. It has also no effect on platelet factor 4 and no immunogenicity, unlike heparin. Bivalirudin demonstrates a very favorable thrombin binding dynamics compared to heparin. So while heparin only binds and inhibits circulating thrombin, bivalirudin binds and inhibits circulating thrombin, but also thrombin that has already been bound to clot. And if you recall, when we showed these devices, there's plenty of places where fibrin likes to attach and grow. And so this is a key characteristic that is particularly attractive during ECMO support for bivalirudin. Some of the early experience of using bivalirudin during ECMO was in patients with heparin-induced thrombocytopenia. Shown here are a couple of early case reports. You can see the dates here. These are just barely 15 years old, so very, very young application of this medication during ECMO support. But these are two case reports of patients with heparin-induced thrombocytopenia out of Germany and Italy that demonstrated a satisfactory outcome of using bivalirudin for anticoagulating during ECMO support. The group in Milan, Italy, led by Marco Ranucci, were the first to systematically evaluate the use of bivalirudin during ECMO. This was their very small case series of patients post-cardiotomy after cardiac surgery that required ECMO. And they gave half the patients bivalirudin and the other half heparin. And you can see here that the bivalirudin patients bled less, particularly early on in their ECMO run, and they also required less transfusions. Another study out of Johns Hopkins looked to identify the relationship with timing and bleeding and thrombotic events on ECMO. And most of their patients received bivalirudin for heparin-induced thrombocytopenia. But you can see here that the patients that received bivalirudin required less transfusion of all the products that they quantified. Our group performed meta-analysis on available evidence of comparison of bivalirudin to heparin in patients supported on ECMO. We found that circuit thrombosis was significantly less in patients anticoagulated with bivalirudin on ECMO. Their bleeding was similar compared to heparin, and there was an improvement in mortality. But really the caveat here is that these are observational studies, and most of these studies demonstrate ECMO programs that transition their program to using bivalirudin as a primary anticoagulant. And so really the evidence demonstrates earlier application of bivalirudin, and as we move on with time, we're learning how to manage complications on ECMO better, and so this might be a reflection of this finding here. Among studies that compare heparin to bivalirudin, bivalirudin patients appear to achieve a satisfactory APTT more frequently than heparin patients. Shown here are several studies that compared heparin and bivalirudin. You can see bivalirudin outperforms in the percentage of time spent in a therapeutic anticoagulation range compared to heparin. Continuous renal replacement therapy is often used concomitantly in patients on ECMO. These patients are critically ill. In general, CRRT does not appear to meaningfully affect bivalirudin concentrations that much, even though about 20% of it is excreted by the kidneys and it is dialyzable. But you can see here the doses are variable, but the ability to achieve a satisfactory APTT is not altered, and so it's safe to do this. When using bivalirudin, developing an institutional protocol has been found to be beneficial in terms of outcomes. These are very interesting data from the group at University of Pittsburgh, where they introduced a standardized dosing protocol for bivalirudin in ECMO. And you can see in the table here, after implementation of the protocol, these are all comers in both pre and post protocol receive bivalirudin. After the protocol, patients were more likely to achieve therapeutic APTTs, and they were less likely to have deviations in the supratherapeutic or subtherapeutic range. And even by doing this, they were titrating the drug less, and they were not compromising on the hemorrhagic or thrombotic events. One very important consideration with direct thrombin inhibitors in general, and particularly with bivalirudin, is the dose-response relationship, particularly as you get to much higher doses. Shown here are data from our center of over 7,000 APTT values from over 200 ECMO patients. And you can see at low doses of bivalirudin of less than 0.21 milligrams per kilogram per hour, there's a really nice dose-response relationship where increasing the dose, you have a nice incremental increase in APTT. Here it was about 11.5 seconds for every 0.1 milligram per kilogram per hour increase in bivalirudin dose. But after you exceed this dose of around 0.21, that dose-response relationship severely dampens. And we found that it was only about 3.8 seconds for every 0.1 milligram per kilogram per hour of dose increase beyond that rate. And this doesn't seem to be the traditional resistance phenomenon that you experience with heparin, because bivalirudin, of course, does not require a cofactor. It directly engages with thrombin. Instead, it appears to be an inflammatory interaction with measuring the APTT. And so these are data, again, from our group where we sampled patients at the same time and we measured their APTT and a calibrated chromogenic ecrin assay that quantifies bivalirudin concentration. And you can see in these patients at higher doses of bivalirudin, increasing their bivalirudin rate maintains their APTT flat. It was just not changing. But if you measure their ecrin concentration, you can see that there's a nice dose-response relationship and the ecrin concentration increases. So although the APTT does not change, the actual anticoagulant effect is increasing with higher dosages. And this is very important because we found this phenomenon to be particularly relevant in patients with COVID-19 and younger patients that are supported on ECMO tend to require much higher doses. And so using calibrated assays like chromogenic assays or dilute thrombin time might be beneficial in these patients on ECMO. Another very relevant and very important consideration for bivalirudin use during ECMO is its metabolism. Bivalirudin is metabolized in the plasma by esterases, and it has a very short half-life. So if you stick bivalirudin in a cup and you just let it sit there, after an hour, the cup will coagulate. And it's because the drug is being metabolized by the esterases. This is a very interesting case report out of Stanford. They performed a heart transplant on cardiopulmonary bypass using bivalirudin because the patient had heparin-induced thrombocytopenia. And shown here on the left-hand side of the screen is the venous reservoir from the cardiopulmonary bypass circuit. And when they evacuated all the blood from the venous reservoir at the end of the case, they found this very large thrombus layer in the venous reservoir column. And this is despite having an ACT of nearly 500 seconds throughout the duration of the case. And so when you're using bivalirudin, you should really avoid it or be cautious with it in situations where you have low ECMO flows or areas of stagnant flow, or if you have severely impaired left ventricular function or very low pulsatility. There's some very interesting and exciting evidence that will be coming on the horizon soon. There's 2 registered randomized trials in clinicaltrials.gov. One you can see here is recruiting in Australia, and another one that is set to recruit soon in China, and also some Cochrane review evidence is coming soon. And with that, I'd like to thank you for your attention.
Thank you very much. Really enjoyed that talk. I'd like to invite all our speakers up to the podium for our Q&A session. It's great to have you all. I'm going to wait for the audience to start their first question. Does anyone have any questions? Yes. Could you please bring a microphone?
Mike, please.
Thanks very much. This is a question for Dr. Dazer. Great presentation. Assuming the patient's falling resuscitated and you've looked at agitation, other causes of heart rate, agitation, et cetera, what would be the role of just switching over to phenylephrine rather than maintaining norepinephrine? Any thoughts on the pluses and minuses of reducing the the beta-1 load?
Yeah, that's a great question. It was actually kind of one of the debating questions that we've had over the past few weeks. So there's and it varies between practice, but we have a general impression that if you switch from norepinephrine to phenylephrine, that it may cause less tachycardia, assuming that norepinephrine is the primary cause of tachycardia for that patient. We've seen it help with some patients, but then the question is, are you compromising other things? So if you're switching to phenylephrine and you're controlling the heart rate or relatively reducing the heart rate to a point that's more reasonable, are you compromising other factors in terms of the outcomes in a patient with septic shock? Because we understand, or at least the literature supports the use of norepinephrine as a primary vasopressor. So it brings us back to that point of whether normalizing a value, and that's, a lot of times it makes us feel more comfortable looking at a heart rate that's, 80 or 90 as opposed to being 190. Does that really help the patient, or are we masking something else by going into a treatment that's not considered the primary drug of choice for that patient, at least within that condition? One thing that we've tried to do at certain points, again, assuming that we were smart enough to feel comfortable saying that we've eliminated every other cause of tachycardia and it's only this drug-induced tachycardia that we're dealing with, which is also debatable and many times, but let's assume that that case is more of a drug-induced tachycardia. We've tried to do the combination of both, where we try to go down on norepinephrine and go up on phenylephrine. There's always the option of adding vasopressin, so that's another option that we can go with. But we've had cases where we've gone very high doses of phenylephrine to try and stop the norepi, and we've questioned that, whether that's really the best choice for our patient or not. So again, it's a point of debate. I probably wouldn't feel comfortable completely discontinuing norepi and going and replacing it totally with phenylephrine, just based on what I've mentioned earlier. But there's the option of, again, adding vasopressin, and there's a lot of literature in terms of adding vasopressin sooner. We could probably add some phenylephrine and keep norepi and vasopressin on board. And then there's also the other part of trying to eliminate other causes of tachycardia, because a lot of times it's not just purely a drug-induced case. So I hope that answers your question.
Thank you. I do have one question. Let me ask Dr. Aneda. In terms of the beta-lactams, have you had experience with using the continuous 24-hour dosing? Did you see any challenges? And do you do any TDM for beta-lactams?
That's a very great question. With the meropenem, we're actually having a problem in terms of stability of the product in the ICU within the specific temperature. So I've never used meropenem as a continuous infusion over 24 hours, but I've used it as an intermittent infusion over 3 hours in like resistant cases and also obese patients. In terms of continuous infusion, most of the time I use it with like ceftazidime mainly, but even with tazocin, we've used it as intermittent extended infusion over 3 hours, but in real practice, I've never used it like 24 hours. No.
Any question? Okay. I have a question for Dr. Anud. Okay. So lately, and unfortunately, during the COVID era and the seasonal flu, we encountered a couple of patients that asthmatic patient, they come with severe asthma exacerbation, and they're refractory and they're hypoxemic despite on mechanical ventilator. They end up with a VV ECMO to support their hypercapnia. So do you think, is it like the time to use ketamine as a standard of care as bronchodilators? Because such patients, we have to make them sedated, rested at least for 24 hours with whatever agent that we have to make them happy and sedated. But lately in our practice, I'm not sure whether this is evidence-based or not, we use ketamine as a bronchodilator infusion till they improve. So if there is any evidence that support this, especially in ECMO patient or critically ill, as an asthma exacerbation or status asthmaticus.
Thank you for this great question. Well, there are tons of literature that I haven't included in the aspect of asthma exacerbation, but I'm gonna extend it what I have mentioned in COVID-19 patient, where you need improving in the oxygenation and BF ratio. Still, our study is a retrospective study. Certainly, we need more study in that aspect. However, we encounter there is an improvement in oxygenation as well as in BF ratio in patients who have ketamine-based sedation. Doesn't mean it's a solo agent or it's the primary sedative, but that was a standard of care plus having ketamine as one of the key sedative in those patients. Well, if we look to the characteristic that I have mentioned earlier in the presentation, it does have a bronchodilatory effect. I don't have any contraindication in using it in those patients. However, I think it's yet too early to have it as a standard of care or a primary sedative. We might need other. It should be included in our ICU sedation protocols with having special populations such as ECMO patient or COVID-19 patient, ARDS patient, H1N1 patient, as well as asthma or COPD exacerbation. Probably over the next few years with maybe the updated version of our sedation and guideline and pain agitation delirium guideline, we might have a clearer answers to this question in a specific population.
Great.
I do have a question for Dr. Anyone from the audience? Okay, we'll start with the audience first.
First, I'd like to extend my gratitude to all of the speakers for their informative talk. I do have a question for Dr. Ahoud regarding ketamine. It is interesting that ketamine, despite that it preserves the respiratory function, it did increase intubation when used early by the EMS. So I assume this might be related to the laryngospasm that it might cause, but I wonder if this outcome was dose-related somehow or...
Very great and thoughtful question. Well, the study that I presented or the systematic review about the pre-hospital setting have mentioned that the increase in the intubation, well, the total intubation rate was 30%, whether it was this patient has been transported to the hospital by air or by ground. While the ground transportation, it could be related to the delay in the time of transportation and that the patient needing intubation versus someone air transported or the one who got intubated in the ED, which is the lower extent. That's the only justification I would think of it. In the study, they didn't give further justification about what exactly happened with the grounded transportation. However, we have 30% of overall intubation rate. So the only thing of it, I think it's the duration or the timing of a transportation. When you have delay with the grounded transportation has led to higher rate of intubation.
Any other questions from the audience? Okay. I'd like to ask Dr. Patrick, what are your thoughts about no anticoagulation, especially in the setting of high flow?
That's a great question. So this comes up quite often, especially when patients are very coagulopathic, and especially when they are cardiac surgery patients, because surgeons are very concerned about their their cases. This is an area that's still being explored. There's currently a trial going on in, I think it's Toronto, Canada, where they're testing this hypothesis, but it's specifically in veno-venous ECMO patients. And so I think that's where the potential lies, is patients on veno-venous ECMO, particularly, like you say, if they're receiving high flow. Usually there's a belief that if there's a fibrin or something in the oxygenator, or on the post-oxygenator side, that embolism of that type of fibrin is less consequential in patients on VV ECMO than VA ECMO. But I think it really needs to be balanced by the adequacy of the membrane. So although you can definitely get away with no anticoagulation for some period of time, some patients are more hypercoagulable than others, and it's really a risk-benefit ratio if you're willing to accept maybe needing to change out oxygenators more often versus letting patients have a little bit of bleeding.
I can ask another question, maybe opposite of Afrah's questions. I remember one patient with a VA ECMO. She ended up with VA ECMO because she has a massive pulmonary embolism that she ended up with embolectomy. We faced a problem with anticoagulating her with heparin because she needs anticoagulation for the high risk of thrombosis in VA ECMO and stroke peripheral thrombosis, plus we need to anticoagulate for an PE. But we face a problem with resistance on targeting therapeutic heparin. For like a period of time, we're not certain why this patient is not being able to be anticoagulated with heparin. So you think we consider early starting bivalirudin instead of facing this problem on anticoagulating patients on being on standard heparin infusion?
Yeah, I think the situation you describe is actually the ideal situation to use bivalirudin, because again, if you think back to the pharmacology, the bivalirudin can bind and inhibit the thrombin that is already established in clot. And so if you have extensive thrombosis, and you have already developed thrombosis, the pharmacology says that bivalirudin is actually more effective in that situation, because heparin would only prevent the propagation of what's already there and not inhibit any of the thrombin that's already developed.
Sure, because it should be a next upcoming clinical practice, because this is a horrible case and we could not even anticoagulate her till like took a time. We didn't think about bivalirudin at that point.
Yeah.
But it has to be in next practice. Any questions? So we are on time. Thank you very much for the speakers and the audience, and time for coffee break. Thank you very, very much for your contribution and your attendance.